Her experience has encompassed a variety of settings, including Zoom Care, Go Health Urgent Care, the director of the Legacy Medical Home Program, and the chief medical officer at Legacy Mount Hood Medical Center. She continues to care for patients while also running a healthcare consulting and coaching firm, Novella Insights. We're so delighted to learn from you today. Thanks, Dr. Say.
Thank you so much. So I really appreciate being here. Good morning. How's everyone doing? Doing well? Okay, great. Yeah, thank you for that kind introduction. And I appreciate you all being here today. And I want to thank the wonderful organizers, Laura and Irene and Mike and Alex and more for having me here to speak about Clinic of the Future. And this is a special thrill for me after many years of attending this conference as a frontline PCP. And it's great to see so many familiar faces in the audience. So let me start by asking you, what if your clinic didn't run on crisis mode, but on flow? Welcome, just take a seat, folks. What if care could happen beyond this discrete packets that we call visits, in which we feel pressured to meet every single need, and could be more like a river that flows through office visits, but also virtual visits, phone, outreach, that could be proactive, messages, and more? What if we could lift morale, reduce burnout, and stop losing PCPs? I believe that's the promise of Clinic of the Future. So I'm here with you today because I'm a little obsessed with redesigning primary care. Why is that? Well, really for about the past 10 years or so, I feel like I've had a front row seat to our system kind of going a little bit bananas. Yeah, I see a few reactions out there. You know what I'm talking about, right? And that front row seat has been from different angles. So stage left as hospital chief medical officer, center stage as urgent care director, stage right as medical home director, all around the place as practicing PCP. But they all show the same kind of spectacle of our healthcare system about to go over a cliff of unsustainability. And sometimes I think we're already over the cliff, but we might not always realize it or want to admit it. So because I'm somebody who wants to always kind of look around the corner, see what's coming next, and prepare for it, I want to be there to either cushion the impact or pick up the pieces and build something new. So I started thinking about redesigning our healthcare system to make it make sense, starting with primary care because that's where my clinical heart is, and this brings us to Clinic of the Future, which we'll explore together today. I believe that thoughtful, responsible use of futuristic tools, along with other important elements like the trusted multidisciplinary team, strong clinical protocols, the flow of care, and what I also call the personalized cookbook, will allow us to craft a sustainable primary care system that works for all three important players: the patient, ourselves as the healthcare workers and staff, and the business side, because of course the dollars and cents have to always add up. These futuristic tools may be scary or threatening, but I think that we must proactively use them for good if we don't want them to be used against us. All right, so for our agenda, we are basically going to review the clinic of the past and how we got to the clinic of today, discuss what's currently not working so well and make the case for change, and explore potential models of clinic of the future. This is one title for it: more care, less burnout, also smarter care, sustainable care, that sort of thing, and how we can start evolving towards it. Oh, sorry, and one important note as well is that this is entirely my own concept, assembled from other ideas that are out there. It doesn't reflect the views of my employer, Legacy Health, and I'm just speaking solely for myself and presenting an original framework. This is because I believe that business as usual, or the clinic of today, is no longer sustainable. So if anybody would like to meet up sometime and compare notes and talk about how we can redesign care, coffee's on me. I also have no financial disclosures or other types of conflict of interest to disclose. So.
Here's okay. Volume's okay for everyone.
Can folks hear?
Yeah.
Okay, wonderful. So our current model of delivering care is really decades old. I think we all know this, but since then, everything has really exploded in complexity. And we've had tweaks and modifications that have been continually grafted onto the model, and the stress and the burnout grow with each tweak until the foundation looks like that, really shaky, cracked, falling over. I'm chuckling because this is the obligatory, I used AI to create an image and to talk about AI, so that's an AI-generated image for us. So we're gonna go back briefly to the clinic of the past, which was a simpler time, right? The defining feature was paper, so much paper, prescription pads, chart notes, sticky notes on your chart to remind yourself of something. And paper had its frustrations, of course, to be sure, but it imposed a slower pace on the work. We weren't expected to know all of the medical information going back for decades, because you would have to go to the file room and pull those volumes of the chart. And so basically you could only work at the speed of paper. In addition to that, patients were frankly less sick. There was fewer mental health concerns, at least that we knew about. Fewer controlled substance prescriptions, which of course bring their own workflows. There were no MyChart messages because we barely had personal email. Let's talk about back in 1995, for example. There were fewer alternative treatments. People didn't do their own research unless they worked at OHSU. And this was many years before Dr. Google. Of course, they also trusted us. They behaved better. There's a lot of things there. So let's explore how this worked through a case, because as doctors, we love cases. And let's meet Ms. Jones in 1995, okay? Nice lady, 55-year-old woman who smokes. She's got a couple of simple conditions. She takes a couple of simple meds. She comes in for some simple yearly labs. She also gets her annual, remember, that annual pap and mammogram before we started arguing about the frequencies of how often to do these things and having risk calculators. And she got some colon cancer screening either with that FOBT annually or a flex sig and a lipid panel every 5 years. So what do you think? Does anybody remember working in the clinic of the past? Yeah, exactly. Did you know Ms. Jones? Uh-huh. Yeah, what was your day like? It was okay. I see a shrug. Yeah, it was all right. Okay, so we're gonna move right along to the clinic of today. Okay, you can see with my image here, I'm kind of going for like futuristic med spa meets Starbucks mobile ordering, something like that. I'm gonna argue that clinic is much more complex and challenging now for a number of reasons, and so to function successfully in clinic for us and patients, the requirements are just much higher, and that this contributes to a lot of the negative things that we do experience in clinic. And so we're gonna illustrate this by meeting Ms. Jones of today. I think you know her already. One caveat, I had fun writing this case scenario. It's maybe a little bit exaggerated, you be the judge. And a second, more serious caveat, I do really believe we are all patients and we can all have a bad day or not be at our best if we're sick or scared. So basically we can all be Ms. Jones. However, and I don't mean to imply that patients are the enemy, but too many encounters like this can be challenging. All right, so she's still a 55-year-old woman who smokes, but now in addition to those other conditions, she has insomnia, bipolar, and fibromyalgia on her problem list. She's had some access to care issues, so she's saving some things up and she wants it all done at her PAP visit, which she knows she's due for. Check up to talk about some things, the dreaded some things. Not just one med for hypertension, but 3 Seroquel for sleep, my favorite. Armour thyroid, alternating doses every other day, because that's what works, and then the hydrocodone for fibromyalgia. You guys are smiling. Yep, you know Ms. Jones, I can tell, and I know Dr. Andrews would have some thoughts about that hydrocodone based on the excellent pain talk yesterday. Okay, so she also thinks she has adult ADD. She tells the MA on the way in, and she's been taking her son's stimulant meds, but she'd like her own prescription and diagnosis, please and thank you. And then of course the screenings show that depression is really flaring for her, a score of 19, and positive suicidal ideation. And then of course the doctor has to contend with, as she's going into the room, not just all that stuff in front of her, but best practices that flash up usually right in the middle of your workflow and thoughts about something else, suggesting screening now, not just for all the normal stuff, but HIV, Hep C, and lung cancer, per the other talk, with the low-dose lung CT. Okay, so previously we kind of had to just remember stuff and had flow sheets on paper and we got to what we got to, but now we've got all of this right in front of us. The screening guidelines have become more complicated, new items, different frequencies, all this kind of stuff. Okay, so what does our doctor do? How does she handle this visit with Ms. Jones? Also AI generated image. You can see she's not super thrilled. Okay, I think we kind of know why. So she has to think about what will harm the patient soonest, and that's obviously the suicidal ideation far more than the cervical cancer for which the PAP would be screening, etc. So she has to pivot on the fly. I know you guys have all done this so many times, and address that with a safety plan, refilling the Seroquel, although maybe with gritted teeth, but you don't want to necessarily change that psych med when the patient's actively unstable. Warm handoff to the therapist in clinic. Psych referral as well to kind of explore the ADD diagnosis, because that arguably is a little bit beyond primary care. More complicated labs, including the urine drug screen, because we're teeing up for the controlled substance discussion that's going to be coming. And then she just tries to jam in a mammo and colonoscopy referral. Brings back for the next visit. You can see all the rest of the stuff there. It's a lot. Haha, let's do the PAP as well as the lung cancer screening and the meds and the immunizations, etc. So I condensed this into 2 visits, but you guys know it's really probably 3 visits worth of stuff. So that's what the doctor does, and then what does Ms. Jones do? So this is a sad trombone sound. Womp womp. She sends multiple MyChart messages with more questions, about supplements. She requests the hydrocodone early, but she didn't do the drug screen. And she complains to the clinic manager that she wasn't able to address all her issues in one visit because she doesn't like coming to the doctor and she didn't want to pay 2 copays. So even though her care is complex enough to, need this and more. So audience participation, do we know Ms. Jones of today? What does it feel like? Anyone want to shout anything out? Exhausting? Yeah. Yep. It can be exhausting, absolutely. Okay, so this was pretty familiar for us, and now we're going to go through sort of these elements that we combined into this case. Maybe it'll be a little bit therapeutic. We'll kind of spin through this stuff in order to basically have time to design our new approach clinic of the future. But first, we're going to have a joke. So dogs can't operate an MRI machine, but cats can. Right? All right, thank you. So how clinic of today is more complicated. Actually, in another version of this talk, each bullet point gets its own slide, but I'm going to spare you all of that. And basically just kind of dig into why this felt a little bit overwhelming and kind of like a doomed pap smear visit from the start. Patients are just sicker. I'm sure we have fancy case mix index stats, but we know this from caring for them. And so that is shown obviously in the expanded problem list of Ms. Jones. Social drivers or determinants of health. This is really other aspects of the patient's life getting medicalized. So back in '95, we barely understood the idea of food as medicine, much less food insecurity impacting her health, for example. Now we're expected to care about everything in their life, and we do because we're altruists, but I would argue that it comes at some cost to ourselves as well. Furthermore, like I kind of alluded to, drug use, mental health issues, and it wasn't exactly an active substance use issue, but perhaps taking your son's controlled substance med, it's a gray area in that sense. The explosion of medical knowledge, I really think it's beyond what any human brain can keep up with. That's why I'm going to argue for futuristic tools to help us with that. And so many new meds, tests available, classes of meds, risk calculators. We can kind of see that just even minorly in Ms. Jones asking about supplements. We can still give our line of like, I don't really know, I wasn't trained in that, but patients expect this of us. Then we have the EMR and all the other clinical pathways in clinic to give care, and including the explosion of the inbox. So basically all of those messages, the desire for immediate answers, which we'll dig into more. And the EMR, I say this with love because I do love my EMR, but it's a little bit of, brings us gifts of efficiency, but demands a big cognitive load. Okay, maybe a minor point, but a tech gap amongst patients. So we used to just think of patients. Now we have segments of populations. And for example, you have your younger patients who just want to do everything over text, like get their pap smear over text probably, never come into clinic. And then you have your older patients who arguably need more attention and frequent care, and they may have trouble getting onto the portal to read your message, getting onto a video visit, even though being at home would be a lot more convenient for them, et cetera, et cetera. And then of course, I'm not even going to go into the pandemic, but no slide is complete now without an acknowledgement of rising costs, turnover, unionization, burnout, et cetera. And then I will expand a little bit on quality metrics and patients as customers or consumers, because it underlies so much of how we interact with them. But first, a joke. And this relates to that tech gap. So how do you confuse this new generation? Lock them in a house with a rotary phone, analog TV, no remote control, dial-up computer, a stick shift car, and leave the directions in cursive. Thank you. All right. Oops, too many animations. Animation heck. Okay. So talking a little bit more about quality metrics, just because as a former medical home director, they're dear to my heart, but also a double-edged sword. So now you have to do a good job for your whole panel, not just the person in front of you, and including people you've never met before. I think we've all experienced that. We have extra meetings in clinic to go over our metrics. We have things posted on the wall with our metrics, outreach pushes like mailing fit cards. We have quality pushes like Papapalooza. That's a real thing. We have the interest months. Who knows breast cancer month, for example? Shout out. October, yep, exactly. Diabetes month? November. All right, very good. So this showed up in the BPAs in Ms. Jones' care, flagging up for testing extra stuff. And then there's pressure from somebody like a medical home director saying, just jam it a little bit more into your visit, just do a little bit more care so we can stay up and not fall behind. So Now we're gonna also do a little bit of audience participation, and these questions, I'm just saying, may show up later. So 2 questions. How many shots have been added to the adult standard risk immunization schedule since back in '95? Not that they didn't exist, but they weren't standard for all adults. Anybody have any, shout a number or any shots that you know have been added on? RSV, shingles, Hep B for everybody. COVID, yes, no, you guys are right. By my count, and I just pulled up an old one and compared it to the new one and asked ChatGPT, 6. Okay, so pneumovax, shingles, HPV, Hep B, COVID, and RSV, obviously those being completely novel vaccines. And again, it's not that all the others didn't exist, but it was more like specialized and you didn't have to kind of give them to every standard risk adult. How has the triple aim been expanded to the quintuple aim? Anyone know? Because now 3 things aren't enough, we need 5. Okay, the triple aim, I won't torture you. The triple aim was patient experience, outcomes, and value, which made sense, but then we added on as well healthcare experience or healthcare worker experience, and also health equity in that dark gray area. So again, just expanding stuff. Okay, I think I have crazy animations here too. All right, so next thing that I want to just expand on briefly is patients as customers or consumers. So let's be honest, they no longer do what we tell them to do because we know best. No, who said that? Now they're consumers, okay? They want their healthcare with a side of customer service to satisfy expectations, choices, and preferences. Why? Because they have Amazon and overnight delivery and Uber and DoorDash, and these experiences are designed to satisfy needs almost immediately. And they shift their desires that are honed by these tech-fueled services from other experiences to healthcare. And then on top of that, we've got our surveys, so basically NPS, Net Promoter Score, Press Ganey survey, creating pressure to delight the patient. This actually all makes sense. I don't even mean to blame the patient. We are the patient again, but it's totally understandable. But healthcare was never designed to provide a delightful experience, frankly. So we're struggling. We're struggling with this societal shift in expectations and how we can manage this in the clinic. So here's a joke. When a kid says, "Daddy, I want mommy," that's their version of, "I'd like to speak to your supervisor." Okay, so audience participation. Any thoughts on this? Hitting home, it resonates. Yeah, thank you, exactly. Okay, so basically I see you, I'm right there with you, I get it. So now that we kind of understand what's going on today, let's get to the fun stuff. So designing clinic of the future. And we're gonna go through some principles briefly here and then meet Ms. Jones of the future and how we're gonna handle her care. So, this isn't new, right? Get the patient to the right place or modality at the right time for the right care. But now we have basically, a different way of doing that. We're gonna break the visit and build a care flow. We kind of talked about that. This leads to breaking the clinic because one thing the pandemic did do for us was show us that not all care had to happen within the 4 walls of the clinic. So we have video visits, we can even bring care into the home, which we'll talk about, possibly mobile spaces, like a mobile van. Ouch, break the PCP and build a trusted multidisciplinary team. That kind of hurts, but I think that's actually gonna be better for us as PCPs and the patient. Getting back to the flow, I already say primary care is like a river. Things just drop in, things wash out on the banks, the river keeps flowing. You never get everything done in one visit, and that's okay, but the pressure to do so is kind of part of what feels so heavy at this time. So we're gonna talk about tech and data and metrics, and then we're gonna talk about this idea of the cookbook or protocols to make simple stuff simple, but making it feel personalized for the patient. So this kind of may be controversial. I think that much of what we do can and should be standardized in clinical care so that we have more bandwidth for the hard stuff that needs more nuance and individuality. I think not everything has to be bespoke and customized, even though maybe that's kind of what the patient wants. They want their care to be super special for them, and I get it. That was maybe doable in 1995 when things were simpler. I don't think it's doable now, and I think it fritters away our energies so we don't have the bandwidth for when stuff really gets hard, actually. So, thus, I think we'll save our collective energy. And then how will we make it feel personalized? Well, that's kind of the million-dollar question. I think we need to use human-centered design principles, which is really interesting, and then maybe some other creative ways to do this. Okay, but first a joke. Computers, they're the future. So, I'm not sure we're going to be designing Clinic of the Future with this particular computer. Although what's funny about this is we still use fax machines in clinic, and other people outside of healthcare can't believe that because it's so very 1995. Okay, but now we're going to see how the Clinic of the Future helps us care for Ms. Jones in 2035. I'm not confident enough to predict 30 years ahead. I'm really only tackling 10 years, okay? But hopefully without so much of the overwhelm and frustration. Let's go ahead and meet her. Okay, so she has the same past medical and concerns, but now she's part of a hypertension registry. Pardon. She's got a connected cuff at home. It's checking her blood pressures, dumping them into the EMR, and they're flagging that results are high. So then we've got an AI chatbot that proactively schedules her an evening virtual visit with a pharmacist. She gets blood work drawn in the home ahead of time, not just the TSH and the, need to put the BMP on there, but also that HIV, Hep C, and urine drug screen that she would have gotten done at that visit previously. And the results are available at the visit to discuss. Okay, then we basically have her, at that visit, the pharmacist adjusts the meds, kind of deals with the armor dose based on the TSH, refers to a health coach or maybe an empathetic, supportive patient AI chatbot to coach her on things like lifestyle management for hypertension. Starts a conversation about Seroquel and that maybe we need to move away from that at some point. Answers the questions about pain and concentration and the supplements. And refers to a chatbot for just some basic expectation setting about not taking other people's meds. Maybe there's a module where we can just kind of run that with the person and then we don't have to necessarily have that conversation in person. That might seem wild, but think of how much time that could save, repetitive conversations. Thank you, chatbot. Okay. Refers to the chatbot for the DIVA interview, assuming we still do that in 2035 to diagnose adult ADD, and the other questions. And then as well, the health maintenance registry tells us, yeah, again, she's overdue for the pap smear. Schedules a visit with the advanced practice clinician, but remote screenings before that, again, show up that depression and suicidal ideation. So we, again, convert the pap. We have her come in and see the physician because things are getting a little bit harder, so we're kind of moving up the ladder, who stabilizes the patient, also with a handoff to the therapist on video. Not saying the advanced practice provider couldn't do the mental health visit, but this is just an example of kind of using the ladder of care and different members of the multidisciplinary team. Okay, so in that mental health visit, the physician gets an assist from the AI to basically determine a better bipolar regimen, interpreting the results of the DIVA to make that ADD diagnosis, prescribing a first-line stimulant. We get some education from the chatbot about fibromyalgia and bipolar, lifestyle management. And then we have remote outreach for the other things, the mammo, the colonoscopy, the low-dose lung CT, and these are obviously individualized based on her risk factors, which are known in the EMR. At that mental health visit as well, the fibromyalgia and the bipolar and the ADD, everything is brought up because it's all related and that's natural. It's all on the patient's mind, it's appropriate. But rather than going down these rabbit holes, the doc focuses on what she needs to do and then again uses that easy education option. Okay. Then she comes in for the pap smear visit, and they can focus on what needs to be done in person because we still cannot pap by text, and we can't give immunizations by text either. So she's gonna get that in-person care at that visit. At another time, the results of all those screenings hit the inbox, and the AI generates some draft messages that are edited by the APC because the humans are still in charge here. Okay, it's not a robotic clinic. And then we have a follow-up visit with the physician to basically tie everything up, go over the controlled substance agreement. Eventually, we're going to tackle that hydrocodone using Dr. Andrews' techniques for communication, lingering questions, meds, results, etc. Okay? So this probably feels like a lot. It felt like a lot to me writing it, but this is the complexity of care with a lot of moving parts that we're currently trying to manage in a 1995 framework with a very shaky foundation, like we remember. Okay. So we're gonna pull this apart a little bit and kind of explore that care was a flow enabled by tech. That's kind of one of the main themes. It wasn't forced into rigid time slots that it ballooned beyond, causing stress. It was initiated with the connected device remotely. It happened in many places, at home, with the video visit, with the labs, also in clinic, and also over message. It was protocolized, but also individual, multi-D team, and we were able to more smoothly handle the things that were really challenging in 1995. Okay, and here's a breakdown of which kind of lanes or elements the care fell into. So we had the human team on the left side, and we've talked about those people. We had AI doing a lot, honestly, in the middle. And then we have the idea of the protocols that were cookbook, but also individualized for her. Okay, so we're gonna go into a few of these elements a little bit more. The trusted multidisciplinary team. So instead of kind of the traditional approach, one doctor, one large group of patients, let's rebuild this model as a pyramid. A group of APCs that each have their cluster of patients. The doc knows them all, is responsible for all of them. The patients can be seen by anybody. They trust the whole team. And of course, we keep all the other super important professionals, the nurses, the social work pharmacists, etc. Why not just a PCP and patients? You know, that's how we do it now. Many of us love this. I love this. It's very rewarding. But I think in all the other, in addition to the other reasons that's not sustainable, we've got the looming physician shortage. So in the future, we're going to have even scarcer resources, and we're going to have to really allocate them, you know, to basically everybody working at the top of their license with their skills super respected and working together in ways that make the most sense, kind of not like a hodgepodge of all working next to each other and, you know, sometimes talking. Okay, I also think that this is a win for patients because it gives them a whole team of people who care about them. If one person's on vacation, they can see another. And I think it's a win for the providers in the team because we can trust each other to give good care. We don't have to be like, only I know my patients and only I can make the right decisions. That means we don't have to work as late after hours and we can go on vacation, crucially, and disconnect. And that is good for our burnout issues as well. Okay. We've already explored the middle column of AI, but let's expand a tiny bit on some of it. So what if AI could listen to the whole visit and actually give you diagnoses in real time? I think this would be pretty cool. We already have open evidence. Does anybody use open evidence? Yeah, like a lot of you guys. Okay, cool. So it kind of still functions like up to date where you have to go out of your EMR, open up that other screen, type in your question, wait for it to think. It's still really good. I love it. I love up to date. I know we all do. But what if it were actually listening, for example, in that mental health interview? And what if it actually analyzed things and it spat out likelihoods? So it says, you know, bipolar's on the problem list, but what if it said something like, you know, borderline personality disorder, 30% chance, anxiety, 20% chance, adjustment reaction, 10%, and then it helped you devise a treatment plan in real time based on those likelihoods. That's a little bit of my dream. I think that would be pretty cool. We could also bring it back to Ms. Jones and say, you know, instead of just interpreting the diva, like it can actually give us that information in real time. And then what about some other core uses of the AI? So we talked about how kind of heavy and at times unmanageable the inbox is feeling right now. And we saw messages play a role for Ms. Jones. It wasn't a huge part of her case, but I think that we should name it that messages are care. I like messages. I actually love emailing patients. I've got all the dot phrases and templates and things like that. It's fun, but it's not fun on top of a full schedule as well, right? So if we named it and we said this is valuable care that's really part of the flow and it needs to be compensated and also given time, I don't mean necessarily charging the patient for it, although I know that's one approach, I think that would be better. What about if the AI were in the inbox reading a string back and forth and it said, 10% chance of ever resolving this question via string or via message. And then it could automatically, caringly, empathetically convert that to an actual visit, maybe video with the provider. And we could sort of cut short some of this back and forth with pictures and daily questions and stuff like that, that sometimes tends to happen. It could schedule that visit. It could ask the patient some questions ahead of time, and it could really analyze those answers rather than just like a yes/no questionnaire that kind of drops into our notes at this time. But it's not all about tech, okay? The inbox is also still humans. We're still in charge, like I said. So as providers, we would also have to sharpen up, like basically raise our game, sharpen up our responses. This is in my vision of if everything worked perfectly and efficiently. And we do some standardized approaches like simple language. Recent example in clinic, I saw a provider cut and paste a super jargony x-ray report into a message and say to the MA, just read this to the patient. You know, I mean, good luck, but you know that's going to go back and forth and just generate a lot more inefficiency. We need to take the responsibility for communicating in simple terms that our patients understand. And we also need to not just write a word cloud in response to, you know, some message and blah, 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 and then hope that the MA can make sense of it in conversation with the patient. We should be saying things like, okay, if the patient is doing this, I recommend that. If the patient is doing X, I recommend Y, etc. And that's how we can also kind of take responsibility for sharpening things up. Another place where tech and AI can help us, but I'm not going to talk in great detail about this, would be metrics and outcomes. It's not everyone's favorite thing, but I think if value-based care is going to remain an important part of our clinical world, we can push far beyond the current registries and metrics by using smart technology. We could have risk scores for things like falls and ER visits and readmissions after discharge. We have those things now, kind of, but we're not really like integrating them into the flow of care and being proactive to allocate our resources. So really, as you guys can probably see, my whole question about AI is, are we gonna do it thoughtfully, responsibly for the good of all, or will it be done to us, probably to maximize profits, and basically to solve problems for people who are not the ones seeing the patients. So I think, of course, we have to be thoughtful about it, go towards it, and take control. Okay, now let's look at the last sort of column in that slide where we had 3 columns, the personalized cookbook. So we've kind of talked about this. I won't totally belabor the point, but the basic care in the Ms. Jones example was cookbook, labs before the visit by protocol, health maintenance outreach, education by the bot, okay? But it was individualized, and maybe it's worth kind of going through exactly how that happened. We addressed her suicidal ideation, optimized the med regimen. She got her questions about supplements answered. She didn't have to send a message about it. She talked to the pharmacist. We took her ADD issue seriously. We got her diagnosed and treated. It wasn't blown off. She got an empathetic coaching from either a human or a chatbot about lifestyle interventions. Her labs were a little bit changed based on the fact that she had controlled substance usage with the hydrocodone. Her screenings were individualized, et cetera. So we do need to, of course, highlight this to patients that you are still at the center of the care plan. Yes, we've got sort of a machine, if you will, and we're letting simple stuff be simple, but we're also tailoring it to you. Going even further with personalization though, what if tech could also help us bring even more of a human touch? Like remind us about the upcoming wedding, the granddaughter's graduation. We could chat about that, the hobbies. What if, in the best case, we just had more time back in the visit so we could make those personal connections and have that warmth with our patients? Okay. So we spent a lot of time talking about how we're going to give care differently in the clinic of the future, but let's also take a moment for the patient side of the partnership. This can be a little bit sensitive, but I think sometimes we bend over backwards to accommodate patients, and it can lead to our own burnout. There are certainly varying levels of health literacy, and of course we have to meet patients where they are and that sort of thing, that's our job, but some patients do have room to step up their part of the partnership. For example, some patients can understand some consequences of their lifestyle habits and choices, maybe understand that they can't have it all or have every outcome that they would like in medicine. Maybe we could keep visits to within time limits because we've kind of broken the visit. We have a flow of care. Not everything has to fit within that one magical visit. We can follow up with messages or a virtual visit. And then also we can hold people accountable. This was mentioned earlier today as well, that violence and threatening behavior are unacceptable. And we do have to, I really believe, protect our most precious resource, which is us and our teams, by having, in a sense, almost behavior contract with the patients. So based on, where's Dr. Burnett? His excellent talk yesterday, the to be sure paragraph, okay? So I said at the beginning, I alluded to, I would just talk about something completely different briefly. And that would be direct primary care or concierge care, where you kind of cut out the insurance middleman and you go back to basics, longer appointments, more time with patients, that kind of thing. It's very appealing to many people, docs and patients included. And I definitely don't want to denigrate any appeal or any motivations that draw people towards this. I think there's a role for it in the healthcare ecosystem, but I'm just personally not focusing on it strongly because of a couple things. Question the scalability of it to take care of the whole population, which is what I'm most motivated about. The problems of today were largely created by tech, so I think we need tech to help us with them rather than sort of a tech minimizing approach. And just questions about whether the physician feels beholden to give the care that's wanted rather than the care that's needed with our medical judgment. But I want to acknowledge that I think there's still a place for this, and this can fill an important role for people who kind of don't fit into the clinic of the future model. So what's in it for you? Why should you want to change? This is complicated. There's a lot of moving parts that we've been discussing. People, bots, visits, messages, it's a lot going on. But I think unless we want to roll back 30 years of expanded medical options and complexity, guidelines, and patient expectations, We have to build a better way to deal with this instead of losing all our PCPs to this feeling of unsustainable pressure. If you think about it another way, change is going to happen to us. So the question is just, do we run forward to meet it, or does it happen to us in the sense of a hodgepodge, Band-Aids, fixing one problem at a time, fixing a problem for an administrator, not for us. I say this as also being an administrator. So I think that this model of clinic of the future gives us a roadmap to redesign care that makes sense holistically. How can we evolve towards this? These are just a few points. We're gonna have an audience participation next, and maybe folks will have some ideas to throw out. Building trust within our teams, so many ways to do this, you know, birthdays, holidays, get to know you boards, that kind of thing. Clinical protocols, we can start asking each other, hey, could we align on ordering labs before the visit? That way I could cover for you when you're gone, you could cover for me, the patients know what to expect, we reduce confusion. Try out the AI tools that are out there, like the ambient scribe, which of course would be part of Ms. Jones' care as well. If you like them, push your leadership for more of them. Start talking about protocols for inbox management and lead the way by using your own simple language and your own clear-cut next steps type of communication to reduce inefficiency. And then starting to hold patients accountable as able. And you know, that's kind of probably a big sticky subject, but starting to train them to know what to expect, to maybe come prepared with their list of questions. If there's 10 questions, you know, focus on the top 2, shared medical decision-making, that kind of thing. I say this like it's easy, but of course I've been working on it for 20 plus years. All right, so audience participation. What do you think? Anyone using AI now? Anyone thinking of any other practical steps? Yes?
I agree with your analysis of the situation and pretty much everything you said about
Thank you.
what direction we have to be going in. We at Kaiser Permanente were talking about this 6 or 7 years ago.
Right.
And started maybe
I love it.
never, moves in these same directions that you've identified. We're having to backpedal because there's a problem with this, and it's patient buy-in,
Yes.
patient satisfaction. So our patient satisfaction scores have dropped. A lot of it's just complex reasons, a lot of that's the pandemic, and especially
Of course.
that. But, so now we're moving back into you have a personal physician, you have a PCP. We're trying to get us to do more of our own emails and see
Right.
more of our own patients. And so there's a problem with implementing this.
Yeah.
It's how to get the public on board.
I am so glad you said that. I'll just restate just very briefly. So generally, yes, but at the same time, patients may not love this, and there may be a pendulum of kind of a backlash swinging away from this kind of thing. I totally agree, and that's why I think we've got to be incredibly thoughtful about how we implement this and use a lot of psychology and the great communication techniques and human-centered design. Do a patient journey, where you actually, of course, we are all patients and we know what we feel like in the system, but like an actual structured approach where you would, almost like wearing a GoPro camera, be a patient from before you even contacted the system, moving all the way through care, et cetera. I'd love to talk to you more in detail about that. I kind of wish I talked to you before this talk. No, just kidding. But yeah, no, I think those are great points, is that not everyone's gonna just go, yay, I get to talk to a bot. On the other hand, I do think it's surprising. I partly base this on some of those findings of the folks in the nursing home, petting the robotic seal and like demonstrably getting emotional connection and soothing from it. And not that we can directly generalize, but I do suspect that people are gonna be a lot more accepting soon of techie approaches to meeting, basic human needs. Yes?
So I have 2 questions.
Yeah.
The first one is, in the model you described for the clinic of the future, you still need that index visit to triage all of these into which component of the team each member is going to deal with one of them. So it sounds like, based on what I heard, you can't get away out of that toxic visit that you're trying to stay away from.
That one toxic visit. Well, you notice I constructed it so Ms. Jones just had the blood pressure thing that like got her into
And
care.
The
Yeah.
second question I have is, does the vision account for turnover of staff? Because you're assuming that the pharmacist
Good
is going
question.
to be the consistent pharmacist counseling the patient on the drug, the medication issues, and the APC is going to be the same. The chatbot will not get an upgrade, hopefully, within the first time they see the patient, and the second time, in which case they
Loses the memory.
might be at a different level.
Yeah.
So, does the model account for those transitions in the members of the team or the components of the team?
Well, it needs to. So again, to summarize, turnover, interrupting, all of these wonderful things, and also the one toxic visit still being the index visit. So to the second question, it absolutely does. I saw this when I was trying to push medical home protocols and workflows, how just it would be 2 steps forward, 1 step back, or the opposite, when we would lose so much staff. I'm going to sneakily say that if clinic is a more pleasant place to work and we have greater trust and human relationships amongst the team, hopefully we are having less turnover. But I know that's a little bit of a cheating answer, slightly. I'll come right to you. And regarding the one toxic visit, yes, she still might show up with all of that stuff. I think the difference would be in Clinic of the Future, we would all agree more on how we're gonna deal with that, and we would have sort of better communicated expectations to the patients of like, this is way too much for one visit. We're so happy you came, so we can start working on this. Here's this, this, and this, and this pathway, and you'd still have to do it maybe a little differently than the example was presented, but I mean, very good point, absolutely. Sorry, I think he was first.
But I think my quick expectation setting among patients. I mean, sometimes patients they don't realize that, at best, most of us may have 16 a day, a lot of us have a lot
Right.
more than 20.
Right.
They don't know how many
They don't
patients are on our panel.
I know.
They don't know, it's a little
Right.
bit better since I've had Andy and AI, but, they don't know, patients don't know. I mean, we need like a dirty jobs.
Yeah.
Yes, we make a decent living, but I mean,
Right.
I think patients need to know what's coming and they need to expect less. Quite honestly. The expectations are too damn high.
I agree with you, and that's
We should have them do our inbox for Ed.
HIPAA. That's, I completely agree with you. And I think that sometimes I know I've been very guilty of like, I want to be the best physician ever that can walk in and make them feel like they're the only one in the world.
Yeah.
But really I'm thinking about a million other things and I'm running late and stuff like that. It actually, I think, does them a disservice. I do think that we can get into a little bit of a paternalistic or maternalistic relationship with people where we're kind of like, oh, they're sort of childlike. They just want and want and want and want, and it's my job to satisfy all of that. And that's a little bit more like treating people like adults. Like it's a partnership. We live in the real world. Resources are not unlimited, including time, bandwidth, etc. And so, yes, I think that's why we need to lovingly, empathetically, and very savvily create.
But it can't be like each doc or each clinic doing that. It's like
Yeah.
more of a societal
Yeah.
type thing.
I agree. I love it. Let's work on it together. Okay, I'm just trying to continually improve the content. So if you want to drop some feedback from me, that would be amazing. It's anonymous unless you write your name at the end. And also, as you might imagine, I'm developing a Clinic of the Future Accelerator program. So I want all these ideas and more. Let's stay and talk if you want, and just pull me aside in the conference or reach out to me. Thank you, guys. Thank you. It's really fun. Let's build it together.
It resonates.
Yeah, thanks.
Yeah, thank you. I'm sure
Absolutely.
someone
Well,
stay
I'm
in
glad.
chat.
Yeah, for sure. Did you want to talk?